Welcome to the Healing Pain Podcast with Dr. Joe Tatta. Each week, we interview top experts in physical therapy, pain science, and integrative pain care. You'll learn the most up-to-date information for treating and reversing persistent pain. This podcast is for educational purposes only and not intended to be used as personalized medical advice. And now, here's your host, Dr. Joe Tatta.
Hey there, friends. Welcome back to the show and welcome back to this week's episode of the Healing Pain Podcast. Today, we're discussing the intersection between PTSD, post-traumatic stress disorder, and CRPS, which is complex regional pain syndrome. My guest this week is Dr. Debra Brandt. Debra is a retired doctor of physical therapy. She currently teaches about issues regarding chronic pain and the use of somatic therapy practices. Debra's personal experience with and the study of complex post-traumatic stress disorder, as well as complex regional pain syndrome, which she identifies as being a complex psychophysical phenomena, has enriched her comprehension of both issues and provided her with unique tools to communicate her insights and knowledge to others. On today's episode, we will discuss treatment options, but more importantly, this episode is an opportunity to hear one's lived experience, which includes Debra's personal knowledge of PTSD and CRPS gained through her direct firsthand experience, rather than learning through textbook-like descriptions, which can be challenging to really understand the full complexity of what people go through. Okay, without further ado, let's begin and let's meet Debra Brandt and learn about the intersection between PTSD and CRPS. Hi there, Debra. Thanks for joining me this week on the Healing Pain Podcast.
Hi, Joe. Thank you so much for having me.
I'm excited to have a fellow New Yorker and a fellow PT.
I'm really excited to be here.
We could have did this in person from my apartment to your apartment, but this is good too. I think a good place for us to start, Debra, is to just tell our audience how you became interested in the link between chronic pain and post-traumatic stress disorder.
I became interested really because I had to, because it happened to me. And I got injured in the park. I had been previously hit in the head with a ball. I was out with my dog. So I was already in PTSD, and I got knocked over by a dog and got a really bad 2-foot injuries. And it became chronic regional pain syndrome. And in order to deal with that, it was a very long journey. It started in 2012, and to some extent, it still continues. But it's the injury that continues, not, thank God, the CRPS.
So when we mentioned chronic regional pain syndrome, there's lots of different variations of it. It sounds like you had it in one foot and one extremity. Mm-hmm. And what did that look like? Because sometimes it's just pain for people. Other times it could be intense swelling and discoloration. What did you experience?
I experienced first a pain that I had never had. I mean, I'd had foot fractures before. I had sprained ankles before. And it was a different kind of pain, completely. I think the best way that I can talk about it is that it affected my thinking. It affected my state of mind. It affected how I felt and how I responded to things more than the pain, actually. The pain was immobilizing for about 3 days. I barely got out of bed, but I was gone. I called up the doctor. Well, of course you have pain. You have a fracture. And I said, but I think this is different. She said, well, you can come over, but I can't help you. And so I was with it by myself, as I think people are. And the pain itself, it was very hard at that time. I can't distinguish between the effect of the PTSD that I was living in and the effect of the pain. It was like I was living in a morass. I was supposed to wear a boot. I couldn't because of the pain. To do anything, to put on any kind of anything on my foot, I had to wrap it in cotton batting. And I knew somewhere inside of me that this was not a fracture that I was experiencing. I really didn't know what to do because I couldn't think. And that was, I think that was the most debilitating part of it, was getting myself to the point where I could say, I need another plan. This plan isn't working.
So how long into the process was it where you finally said to yourself, this isn't working, I need another plan?
Okay, not very far into it, and I went to another orthopedist, and he also ignored the pain, and he also ignored the other indication on the MRI or the X-ray that there was another injury. And to tell you the truth, I had another injury, which is broken toe. I had a cuboid fracture and a broken metatarsal. And I mean, it's phenomenal, but he actually made me scream in order to, I don't know what, show that I was a pain patient. And then he ignored that this was a fracture. He thought it was, I don't know, some kind of swelling or something. Sent me to PT, and the PT ignored it, I'm sorry to say. And also said, well, if you don't do that, she was trying to get me to go up on my toes, and I couldn't. And she said, well, if you don't do that, you're just not going to get better. So it was an evolutionary, as I think it is, I don't think I'm unique that way. It is an evolutionary process where you try the next thing and either it works or it doesn't work. And then you have to try the next thing and that either works or doesn't work. And one of the things that I want to say is don't stop. Don't give up. Because you might have to go through 10 things that don't work. You may be disappointed. You may be having continued suffering, really. And it's easy to be angry. It's easy to be despairing. It's easy to be frightened. And I think those are perfectly normal, natural responses. Just an untenable situation. And, broadly speaking, it was an untenable situation, but I've been in many untenable situations, and so has everybody, And a very important part of any untenable situation is to not give up. And I have here a poster that I got from UNHCR, the UN Refugee Agency, of a bunch of people on a boat in the middle of the ocean. They're refugees. They're escaping. And it says, the only thing stronger than fear is hope. Mm. And I live by that. And I encourage people who are facing untenable situations physiologically, even emotionally, if they can dig up some hope, it really makes a lot of difference.
And the story that you're describing is not uncommon for chronic regional pain syndrome. It's very misunderstood by well-trained professionals on all levels of the healthcare spectrum. And people go misdiagnosed quite frequently. And when someone goes misdiagnosed, then it becomes, as you mentioned, it becomes a search for, okay, if I can't get an accurate diagnosis, who even cares what the diagnosis is? I just want to start to find the solution, start to find some relief, start to find ways to get my life back, so to speak, right? So what did you try initially to try to remedy your own CRPS?
That's such a complicated question. The answer to that is very complicated. And I do want to put in here that I was very lucky that I got properly diagnosed after 4 months. People go for years and people have surgeries that don't work. Mm-hmm. And thankfully I did not. So I made a list. I thought maybe I would just read the list. It's not in any order. In brief, I went to my internist because the PT I was going to wanted to treat something else. She wanted to treat my Achilles tendonitis, and she couldn't because of the pain. And so I ended up going to my internist, who I said, there's swelling here. I don't know why it's still swollen. He squeezed my foot. I screamed. He said, go get 2 MRIs, one for each foot. And then I took those MRIs to my podiatrist, my trusty podiatrist who has been my standby. Maybe I'll say his name, Dr. Novella. He's just a wonderful man. And he said, have you thought about going to a pain doctor? And I said, no, why? And he said, well, I think maybe you have CRPS. And we studied it in school, I said, of course I'm going to a pain doctor. It's really interesting because by the time I got to Dr. Novella, I had, I believe, already created a third leg. This is one of the ways that you cope with an untenable situation. You fix it. I created a third leg. It's never been clear to me whether that third leg contained my pain or that was the third leg I was walking on. I'm not sure which it is. And that third leg stayed with me until about a year ago, from 2012, when I was talking to my osteopath, has students that he trains, and he always asked me to talk to them about CRPS. And I was talking to this student about my CRPS, and I said, yeah, I created a third leg. Oh, it's still there. Oh, okay. And it went away because it came to my attention and I didn't need it anymore.
So explain to us the concept of you conceptualizing this third leg.
It was a surprise to me. I didn't know it was there. But when Dr. Novella said, a pain doctor, and I said, why? And I had CRPS. I think that I can only say how I understand it. Let me give you a really quick explanation. Oliver Sacks wrote a book called A Leg to Stand On. And it's a story of, it's a story of how he was hiking in the Alps by himself, got chased by a bull, fell down, broke his leg, had to get himself off the mountain. He was by himself. And his rehab, recovery from the fractures and his rehab, and he still couldn't use his leg properly. Now, he's a very physical man. He was a weightlifter, brilliant. Everything was going for him, but he couldn't reintegrate that limb back into his body schema, his system. As I recall, the story goes that I think it was his rehab doctor called up, he swam on a regular basis, and the rehab doctor called up the lifeguard at the pool and said, sometime when he's sitting on the edge of the pool and he doesn't expect it, just push him in. And that's what happened. And it got out of here and into here, and his leg came back to him. Mm-hmm. Now, I think that it can happen when physical experience is so traumatic, just like if an emotional experience is so traumatic, that it's not manageable. You fix it in order to go on with your life. And there are a lot of ways of fixing it. You can deny it this way, you can deny it that way. I denied it by creating a third leg where I guess the problem lay. Thankfully, I was able to give it up because I didn't need it anymore. As far as the actual pain of the CRPS, of the actual injury from the podiatrist, I went to the pain doctor because I also have idiopathic peripheral neuropathy, and he did a diagnostic. At that time, they're not doing it now, but at that time, and even at that time, I think it was not, they were already stopping doing lumbar blocks, but that's what he did. He did one lumbar block to see if it made any difference, if it was the peripheral neuropathy I was struggling with or the CRPS. And it was effective. And I really didn't care which it was. I thought this was effective. I knew it wasn't going to fix things, but what it allowed me was time to think, because it did interrupt that cyclical alarm that was just going on and on and on and on and on, keeping my foot purple and mottled blue and red and white. You asked, and swollen, and it was creeping up from my foot across my ankle. Went up about 5 inches up my leg. It does travel. It's this inflammatory process because your body's trying to fix what somehow your whole system thinks is wrong. And it's like my understanding is, to some extent, is, to the extent that I understand it, or that anybody does, is that it's really a positive process that goes awry, doesn't know when to stop. I had 3 lumbar blocks, and at that time, and I was given the chance to think. I also was with an extraordinary doctor who's not working anymore, but he started the CRPS program at Mount Sinai. And I'm not sure that exists anymore, I don't know, but he's not practicing. And he connected me with RSDSA, which I think people should know about, rsdsa.org, if you should know someone who has CRPS, Reflex Sympathetic Dystrophy Association. And with a really terrific behavioral therapist who I went to just a few times. She was extremely busy, and I sort of had to fit in here and there. I went to her a few times, and I did heart math with her. I'd already been in psychotherapy for years, but one day I came in and I said to her, I feel like a fly on hot horse shit. I just can't settle down. And she said, well, would you like to try doing heart math? Okay. What else? What else am I going to do? And I did, and I managed to settle everything except for one thing. And I said, okay, I got myself organized and I'm in control. But there's this one thing that's not. And there's this pain in my foot. And she said, that's the CRPS. She said, that's your injury. That little pain is what this is all about? And she said, yes. I said, oh, and it went away. It was a little teeny pain. The actual pain. The baggage that came with it, the basket that it was in was huge. And
so hard math made you realize that there's a difference between the sensation we identify as pain and all the other cognitive based aspects that we put on top of it.
Reframe it a little bit differently to say that it gave me the process that I went through to get it's a biofeedback thing, to get the biofeedback, informed my body and my brain about how to calm myself to the point where I could actually feel the actual pain. What I was afraid of, and I'm making a link right now, that what I was, and I think, again, I don't think it's just me. I think that the alarm system that goes off, and I studied NOE, Neuroorthopedic Institute, and I think that they're thinking worked very well for me, very well. The alarm system that gets set off, for me, I think linked to my complex PTSD, which is an alarm system that keeps going off.
That's right.
And the alarm systems just multiplied, like it wasn't additive, it was multiplicative, And the heart math gave me the opportunity to get control of that system that was in control of me, so that changing of direction is what allowed me to experience the pain. Also, I trusted her. She was wonderful. She was an art therapist. She was trained in heart math and in behavioral therapy. She was really very highly skilled and very wonderful woman for me. I felt in control enough. I felt in control enough to let myself experience the pain. And that was so pivotal for me. It wasn't the end, but it was pivotal. There were many steps along the way that were each one of them was pivotal. Not a single one of them would have worked by itself.
So there's this concept of a third leg, which is a coping mechanism that you developed early on. There's heart math, which is really biofeedback. Biofeedback help you realize, okay, what systems are working here? What's kind of running my life? And how do I manage this? How can I calm this down, so to speak, right? The pain system. A good way to calm down the pain system is through heart math.
Heart math was a vehicle that I was able to use to get control. Heart math didn't do anything to me.
Right.
Heart math gave me the power, informed me how to reach the power inside of me that allowed me to whole enough to tolerate experiencing the pain. It did not happen in my brain. It happened in my body.
So that's really important what you just said.
Yes.
Because so much we talk about the brain being responsible for pain, or the brain and the nervous system, which technically it is, but it is still a somatic experience. And ultimately, even if you're using a cognitive approach, ultimately you still have to integrate the body and all the awareness that goes along with that, the somatic approaches, into the rehabilitation of someone with pain, right?
Yeah, and not just the neuromusculoskeletal body, but the organs, the balance in the very most largest sense.
Mm-hmm.
I went on, maybe I'll go on from here, because I'll sort of try to fill in. I got a handle on the original injury after, I don't know, maybe a couple of years. I went for a few years protecting the injury. It wasn't fully rehabbed. It wasn't at all fully rehabbed, but I was able to protect it and go on with my life until it happened again.
So you had a flare up.
I had a flare up.
Yeah.
And at that time, I was also experiencing chronic PTSD, which I want to make the distinction, complex PTSD. I want to make the distinction that Bessel van der Kolk makes between complex PTSD and PTSD from, say, being in a war, an automobile accident, having a life, changing diagnosis. That's PTSD as it's generally acknowledged. Complex PTSD, he makes the distinction, is being in an extended multi-year experience over which you have no control, which is just continually traumatic, like 15 years or something like that, which it was my childhood. So that I was primed. And I read so much research on how trauma primes you for chronic pain. And I could see why. It certainly primed me. So the second time, I knew that if I was going to cope with this for the rest of my life, because it happened again, I wouldn't be able to do it once I didn't have the energy to do it, because it took absolutely humongous amount of physical energy to cope with this. And so I told my therapist of many years, I'm going to research EMDR. And because I knew that was, the sort of go-to therapy for PTSD. I managed to find a wonderful therapist who did EMDR and hypnosis, and I think she was also trained as an analyst, but didn't want to stay in that, area. The person that I've seen for many years is an analyst, and I do psychotherapy with her. And I went on seeing her, but what worked really in giving me a handle on the complex PTSD was EMDR. I held something in my hands and it went buzz, 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 buzz. And again, this is, we were talking about the way in which the body gets involved, or you have to involve the whole body. It got in there under my consciousness because it tapped into the physical experience of the terror, really, And I think it's primarily terror. I think for me, it was primarily terror. I don't know what it is for other people. It could be other feelings. But I think for me, it was terror. I think also there was a lot of anger, and probably my own terror of my own anger, because anger is a big thing that comes up with a lot of pain.
Yeah.
And also with PTSD. But all of those, the terror and the terror of the anger and the terror of the fear and the terror of the injury. Actually, I passed out. It's the original injury. I passed out. I just passed out. I heard somebody screaming, and I figured out that it was me. I was lying on the ground, and I figured out, oh, that person screaming is me. I guess I'll stop screaming. I really do believe that there isn't one most important, there isn't one only important that I would say, but one of the very important aspects of dealing with chronic pain, with the emotions that are mobilized by it, the emotions that mobilize chronic pain,
Mm-hmm.
is to get into an unconscious level of the body, where it's acted out in our bodies. We act out our fears, our anxieties, our pains, our distrusts, our mistrusts. They manifest physiologically, and to get them to get a handle on that complex system, you have to address the system.
And throughout this time period, so you're exploring EMDR and heart math, and you're still moving your body in healthy ways too, because you were a dancer and you're a PT. So that's a part of what you're doing as well, right?
Oh, I never, ever stopped moving. It was, no matter what my experience was, when I couldn't wear that boot, I walked anyway. I said to the second orthopedist, I can't wear a boot. He said, doesn't matter. It's a stable injury. I walked through the pain. I was so afraid because one of the things that happens with CRPS is osteoporosis. I didn't want to get osteoporosis. I didn't know. I asked people, is it a process of the disease itself, or is it secondary process that happens because people stop using it? Nobody could give me the answer. And I decided, I don't need the answer. I'm going to keep walking. And I did. I had to farm out my dog for 6 months. I couldn't walk her. I was extremely limited in what I could do, but I walked. And I did everything that I knew how to do, that I could tolerate doing, that I could think of doing, to stay in motion.
So Deborah, you've been a PT for a long time.
Oh, since 91.
Okay. And you're also someone who has overcome chronic pain and complex PTSD, as you mentioned.
Yeah.
So this experience has informed you as a person. It's informed, how you look at chronic pain and how you treat patients. Based on your education and based on your personal experience, how would you like to see the PT profession move so we can more effectively help people like yourself who are faced with CRPS and other comorbid conditions? What can we do better as professionals to help someone like yourself move through that experience faster, specifically the PT profession?
I have a sort of a broader answer to that. I don't necessarily think it just applies to chronic regional pain syndrome. For example, I saw that PESI is giving a course on women in trauma. Mm-hmm. And I called them up and I said, can I get continuing education credits for physical therapy for taking this course? And I think it's an absolutely crucial course, because for a lot of reasons, among them that we may lose Roe versus Wade. There may be a lot of rehab that may have to come out of that. There may be a lot of pelvic floor rehabilitation. There may be, there are many ways in which women from other cultures that are coming into our culture are traumatized and women in our culture are traumatized, that is specific to being a woman, that will need rehab. PT does not give continuing education credits for that course. To me, that's unthinkable that they would not see the importance of a course like that for physical therapists who are treating women, who are treating women who have been traumatized as women, and not say to physical therapists, take this course. And over again, even the courses that Bessel van der Kolk gives, and he gives courses to everybody, and he's talking about the body. They don't give continuing education credits for that course.
Right. Well, that's why we started the trauma-informed pain care course here, because we realize here, our community realizes how important that is, how important that component is when you're treating someone. PT or nurse or MD or mental health provider, doesn't matter.
It doesn't. It does not matter. It doesn't matter. You have the skills that make you, that you got to get your credential, but that's not the profession.
That's right.
That's the core. And you build from that core out, and you bring in whatever is out there that can support that core. And the idea that people are not directed into understanding the complexity of the brain and the mind. And I have another bone to pick, which is, what do I bring as a physical therapist to my practice? And I guess maybe they can't use words like transference and countertransference, but it happens in PT. I don't know why they can't use those words. Maybe they're owned by the psychologists.
No, they're not. Not in my book, they're not.
But they are pivotal to our profession. And I think they need to be, that OTs, they know about it. They do a psych internship, you know. Mm-hmm. They understand the brain much better than we are encouraged to. And so that's what I think. And I think that would be valuable for people treating people with CRPS. I think even RSDSA is not where I would wish it would be in terms of understanding the psychophysical complex, which is CRPS. Now, there are some people that it's not true for. You know, I'm not saying this is true for everybody, but lo and behold, you get someone for whom it's true, you can change their life, not just get them out of pain. You can say to them, this, you know, look in that direction, you know, this is what I do, but there's this whole other world out there of ways that that we can encourage people to grow beyond what, you know, we get them so that they can walk. Now walk out there and learn, do.
Which the psychosocial skills support that is really what it comes down to. Yeah. And they're important when we're talking about populations where trauma is so involved. And having CRPS, even if you don't have a history of ACEs, of early childhood experiences, adverse childhood experiences, CRPS in and of itself is a medical trauma. It's a medical trauma because the pain that people experience and the disfiguring that people experience is traumatizing. And then typically the course of treatment rarely ever starts off smoothly. Out of all the patients I've seen with CRPS, it took them a while to finally start, as you eloquently did, start to put together the pieces of the puzzle so that they can resolve their condition. However, episodes like this help people understand what's happening, what happened, and as you mentioned, provide hope that they can find those components that they start to put together. Sometimes they're individual practitioners, sometimes they're individual treatments, and when that happens, then people realize, okay, there is light here. I do see benefit happening from this, and I do see it starting to change my life. So I appreciate you coming on to the podcast and talking about your experience, and both from the practitioner side as well as someone living with CRPS. Tell us how we can follow you and find out more about your work.
Well, I have a LinkedIn website. If you look up Debra R. Brandt at LinkedIn. And I'm hoping, I think it's time for me to get a website for myself. And so look for a website coming. And I hope that I can put some more writing. I have some writing. If you Google me, I wrote a blog for NOE and I wrote a blog for RSDSA about chronic regional pain syndrome and complex PTSD. And I'm there a few places.
Great. And we'll link to those blog posts. So the blog post is on the NOE Group's website. And of course, you can find Debra Brandt on LinkedIn. So if you just go to linkedin.com and search for Deborah R. Brandt, PT, you'll find her information there. If you know someone who is struggling with CRPS and complex regional pain syndrome and complex trauma, make sure to share this episode with them and share it with your friends and colleagues on Facebook, LinkedIn, Twitter, and Instagram. If you're on Instagram, take a screenshot of this episode and tag me at drjoetatta.com, and I'll be sure to tag you back. Thank you for joining us this week, and we'll see you next week.
Thank you so much for having me.
Thank you for listening to the Healing Pain Podcast with Dr. Joe Tatta. To subscribe to the podcast and learn more, visit Integrative Pain Science Institute.com. That's Integrative Pain Science Institute.com. Sign up to receive weekly updates, leave a review on iTunes, and share this episode with your friends.